Well, good morning. Looks like someone else has just joined. Is that right?
Yes, yes, she's
The
connecting.
pandas.
So, good morning, welcome.
Good morning.
Good morning. You're Sonia. We're just
Yes,
making a round of introductions. Do you want to introduce yourself?
Yes. My name is Sonia Hernandez, and I am actually a parent support specialist for Austin Independent School District. And I joined this meeting because I would like to also present it in the future to our parents.
Oh, excellent. Wonderful. Thank you. And I love your background.
Oh, we're pandas.
Yeah. Oh, excellent. All right. Thank you. If you would like to share your contact information, you can put it on the chat box, please. So then we can, stay in touch. If I can send you more information, or you can ask me any other questions. So we'd be happy to, provide whatever you're looking for.
Thank you.
Resources or information wise. Thank you.
Yes.
Thank you for coming.
Thank you so much.
All right. So, okay. So sorry about that, Ryan. Ryan was about to tell us about his presentation.
Thank you, Lynn, and thanks for the opportunity to talk a little bit about our work at Davenport SAF-T Systems, which is a very small pre-revenue startup in Minneapolis. And it really began with my father's idea. He's a retired orthopedic surgeon, but practiced for about 30 years and took care of many older adults who had suffered falls and fall injuries. And about 5 years ago, he began thinking about this as he began to approach his 80s and now is 85. And he and his wife, my mom, live up in northern Minnesota, and they have an idyllic life living out in the country, 20 miles, 15 miles from any hospitals or convenient services. And they've been lucky enough to stay relatively healthy. And his thinking about his career as an orthopedic surgeon and recognizing how common fall injuries are among people 65 and above. What a shame for people who have been able to maintain health and been lucky enough to be healthy to then have a slip and fall or a trip and fall, losing their balance and injuring themselves. And so he decided to work on a design that's really meant to not so much prevent the fall, but to reduce the risk of injury in that fall. So we are developing this technology, and we are in search of deep pocket investors, but we believe in this concept. It's well overdue, and we are excited to move this forward. We're in an accelerator program, which helps startups develop their company and their concept. So, Lynn, I have that 60-second video. If you think there's time, I can play that.
Yes,
but I also want
to, and I just wanted to just take one moment to welcome Suzanne Zaloga. I hope I said that correctly. And Ryan Carpenter. He'll be talking to us about COVID-19 and, so welcome, Ryan, number 2, Ryan C. And we went ahead and started just a brief presentation about a product that is being developed. So it should take about 5 more minutes, and then Ryan will come on. Okay. All right. Thank you. And welcome again, Suzanne. All right. Yes.
Thank you.
Ryan D. and Aida's here as well. Good. So, and this is Tommy. See, this is like the place to be. Wonderful. So, good morning, Aida. Ryan, sorry to keep interrupting you. I just want to welcome everybody who's joining. Good morning, Tommy.
Absolutely.
So, good morning, Tommy. So, okay, Ryan, take it away.
Very good. Well, for those of you just joining, I'm working to develop a product that addresses the issue of falls and fall injuries in older adults. 1 in 4 older adults falls each year in the United States, according to the CDC. My father and I developed a concept, an idea to address this issue. We are conducting interviews with consumers about our concept just to get valuable feedback from them. And I've put a link up into my chat area, which allows people to click on that link and schedule a 20-minute conversation with me. We just have straightforward questions that we'd like to ask to sort of better understand people's relative concern about the issue of fall injuries and our plan to address it. It's not a sales pitch. We're not selling anything. We're still developing. So the link is there. It's through the Calendly app. So it's https://calendly.com/Ryan-1195. We'll keep that up there. I have a 60-second video to kind of tell you about our product, our concept, and happy to answer questions afterward. So I will see if I can share my screen. Lynn, can you allow me to share a screen?
Yes, Dura's in charge, so she got it.
Okay.
Thank you.
All right, let me see. It's going over. Let's see if I can do this now. Oops, I'm going to actually back up 1 second, make sure I have all my settings just right. Let me stop sharing for 1 minute. Sorry for the delay. Let me make sure I have everything just right. Okay. Okay, so I'm going to share. Okay. I'm fairly confident that we've got it this time.
When an older adult falls, it can be a life-threatening event. 1 in 4 older Americans falls each year.
Over the course of the 30 years that I practiced orthopedics, it became obvious to me that prevention would be a tremendous thing if you could figure out some way to reduce the severity of injury in falls.
The safety vest is a lightweight, smart vest that senses a fall in progress. A system of airbags inflates in 1/4 of a second, protecting fracture-prone areas of the body.
The idea of the safety vest is to provide a reasonable alternative to an individual who is subject to falling.
10,000 Americans are turning 65 every day. Now, through wearable technology, more seniors can walk with confidence and show their independence with the safety vest.
So I hope that came through sound and video. Yes, everyone, raise your hands. They got it. Very good. So it's a concept that's in development. We're collaborating with the university engineering program. We are participating in a startup accelerator. So we are working on both the engineering specifics, the technical details, as well as in search of investor funding, which is a whole nother project. But as part of this effort, we are looking to better understand the voice of the customer and potential consumers to make sure that when we build this, we build it the right way, and that we take in the feedback that we need so that we don't have to keep going back to the drawing board time and time again to adjust it and tweak it. We recognize that there will be some of that in the process anyway, but we want it to be lightweight and comfortable and usable indoors and outdoors and even at night. So I put a link up in the chat if people want to scroll back to the top. And in that link, you can just schedule time to chat with me for about 15 or 20 minutes just to get feedback and input. We're not anywhere near selling this product yet. But thank you for the opportunity, Lynn, to talk about our effort to address really a public health crisis, which is injuries from falls among older adults. As I mentioned, falls occur at a rate that I didn't know was possible, but 1 in 4 adults falls in the US each year. Up to 50% of all nursing home residents fall each year. That's half. And falls actually occur in hospitals. Patients who are elderly fall in hospitals. And so we have an approach that will address this problem. It's our idea that it will. We're going to test it. We're going to make sure that it's safe and that it's effective.
Thank you, Ryan. I have a couple of questions / suggestions. Is that it sounds like your focus is on seniors, but as a family caregiver, I have met several other parents, younger children who they have seizures, epilepsy, weakness, muscular degeneration. I can see this being useful if you make it in smaller sizes. And well, I mean, you know, sometimes they grow up to be young adults. So, but I would, include other potential users, clients, because they would also benefit from, they also fall, you know.
Sure.
So
In fact,
just to keep that in mind.
yes, we all fall down, and there are segments of our population in which it can be a health risk. And certainly the idea of the safety vest can certainly apply to more than just older adults who are at risk of falling. We'll look at those applications and those opportunities as we get further down our development path. But yes, we think there are opportunities to really provide protection for lots of individuals with lots of different backgrounds and medical issues, and perhaps someday in certain professions and certain trades, there could be an application for this as well.
All right. Well, thank you so much, Ryan. I wish you well, and please keep me updated on progress because, as I mentioned to you, I'm very curious and interested in this. So
there's actually a question, Lynn.
Yeah.
There's a question that says,
sorry.
Is the vest hot? This is Texas. Overheating might be an issue.
Mm-hmm.
Well, it's certainly a consideration that we intend to address. We envision the vest being lightweight and breathable. Although the concept that's in the video might suggest that it's maybe a warmer outerwear garment, there could be different approaches, and we'll have to engineer the best solution. It may be that we have an indoor and an outdoor version. Right now, we're just proving out that our sensors that are in the bag and the microprocessor and the inflation system all work together to protect people in a fall. Once we are confident in how that functions, then we're going to begin to design vests that can address different climates, that can be okay in the rain, that they can get wet. So we'll definitely start with the core functions and then build out so that we can address and accommodate people in all parts of the country and the world.
Wonderful. Well, wonderful. I think it's great to think about it. It's really fall protection, really. You know,
it is.
Yeah. Thank you so much.
Yes, thank you all very much for the opportunity. It's definitely fall protection. It's not fall prevention. We think fall prevention is a great thing to engage in, but we know that as we get older, we have to be 100% correct in not falling, and that's pretty tough to reach 100%. So let's identify something that we can do to protect people when they do fall.
Excellent. All right.
Thank you
so much, Ryan. I wish you well.
Take care.
All
okay,
right.
Bye-bye.
Bye. All right. Thank you so much. And let's just welcome the other persons that came, Tommy. I know he was on the phone, so I'm going to respect that. Aida, thank you. How are you doing today?
I'm doing great. Thank you.
You want to just introduce yourself?
Yes, my name is Aida Cerda Prajak. I'm a community health worker for Central Health. Central Health, we provide the MAP program, the medical access program, and we have the community care clinics. So I do outreach all the time. Seniors are a special group of people to me. I've always been interested in senior issues, especially now that I am a senior. I just turned the big 6-0 in April. So yeah, falls is
Yeah.
thank you.
All
Thank you.
right. Thank you, Aida. And if everybody who would like to be contacted, please enter in the chat your contact information, because there might be others here who might, need to speak to you or contact you. Okay, so feel free to do that. And Suzanne, can you hear us? Are you there?
Sometimes people are at work, and so they have it on in the background, but they have it muted so that they're not.
Yeah, okay, and that is perfectly fine. Whatever works for everybody. We're just happy to hear you. I just wanted to give you an opportunity to say hello if you wish to do that. So, all right, without further ado, let's move on to Ryan Carpenter. Welcome, Ryan. Thank you so much for joining us. And I'm going to let you introduce yourself because you do that best. All I can say is that he comes very highly recommended because everybody says, oh, Ryan, you love him. So I am sure that there are good reasons for that. All right. So welcome again. And please introduce yourself and then talk to us about COVID-19.
Hi, guys. I'm Ryan Carpenter. I know several of y'all. Pardon me if I get a little long-winded. I tend to do that sometimes. But thanks for having me.
We're in a time budget, so we'll let you know.
Right. I'm an adult gerontology clinical nurse specialist, which is one of the 4 types of advanced practice nurses. And I currently see residents in South Austin. I have about 400 residents on service at any time. So I've done this for about 10 years, and my practice is strictly confined to the geriatric population. And I've worked in all settings, from the Seton Hospital system, caring for the seniors there as they come into the hospital, through the skilled nursing facilities. And currently my role is Director of Assisted and Independent Living for Austin Geriatric Specialists. We're the largest geriatric provider in the post-acute space in Central Texas. So they had, Michelle Newman had reached out to me and asked me if, I'd be willing to kind of give some of my insight from what I've seen recently with the changes in COVID and the emerging kind of myths versus new data we're coming out with, just to share with you guys. But before I kind of drone on and reinvent the wheel, so to speak, I want to see, does anyone have any specific questions or any myths that they're hearing repeatedly out there that they wanted me to kind of dispel or confirm before we really got into it?
Well, I have something, but
Sure.
if anybody else has a comment or question. Okay, I have a question and a comment. Number one, this horse dewormer thing. Oh my gosh, please, people. Okay, so if you can just touch on that, please don't do it. Okay, yeah, but please just briefly touch on that. And the other thing is there's a family caregiver who moved her mother into her home to take care of her. And the mother has COVID now. And how can she best protect herself from, and now the daughter and family caregiver is starting to have some symptoms of congestion. So how can someone living with you, how can you protect yourself from catching COVID-19 if you're living with a person who's sick?
Okay, those are great questions. First, you're right. The horse dewormer, the livestock dewormer, ivermectin, is one of these things that has kind of come out of the woodwork and has become part of the lexicon when talking about COVID, to the fact where it's almost kind of become a fact. Do not go down that road. Talk to your doctor, obviously, before you decide to try something like that. A lot of those medications are very hepatotoxic, which means they act by going through the liver, and they can really do a whole lot of internal organ damage by taking stuff like that. The other one is the hydroxychloroquine. There was a big push use that when COVID was really emerging in 2020. It's never really been proven to be effective at reducing mortality or morbidity with this disease. So make sure you're leaning on your medical professionals to get the most up-to-date information. And I did want to kind of preface by saying, I'm not political. I'm not politicizing this conversation. Whatever your personal political views are yours, and I respect that. I'm here to just give you a medical aspect of what we're seeing, especially in our very frail population, which is my specialty, the geriatric population.
Ryan, a comment?
Sure.
I'm a retired pharmacist, and I had a friend call me a couple of weeks ago. Her daughter and granddaughter were very ill with the COVID, and she was saying she wants to take the ivermectin. That was the first I'd heard of it. So I did a bunch of research looking up stuff, and what I found was that there was a paper posted, and it was very favorable towards ivermectin. However, upon peer review, they found some serious flaws. They were counting their victories more than once. Yep. And after peer review, it was actually the people who posted it took it down. However, in the time it was posted, it was quoted a whole bunch by a bunch of people. So yes. Of course, you can't do anything about that, but that just shed a lot of light on it to me, that once other researchers started looking at this and evaluating it, pretty much shot it down.
Thank you. And that is, in a nutshell, everything I wanted to get across today, what you just said. We live in a society where the instantaneous nature of social media and a little bit of data comes out and it gets vetted as being fact before it's ever truly been peer reviewed or put through the proper rigorous processes of vetting that stuff. But it gets released into the ether and becomes, sort of biblical fact at that point. You're exactly right. We got to really watch that kind of stuff. I'm not saying any of these don't have any value, but they need to be, as you said, peer reviewed and go through the proper processes before, people make these broad sweeping generalizations about the use or disuse of these medicines. And that's something very unique to us in this time period of our lives, is that we have such access to data and this just mountains of information coming through about this illness. I was listening to someone speak the other day, and they were using the analogy of polio. When polio, the epidemic of polio was sweeping the country before Jonas Salk invented, the cure for polio. It was just, the data wasn't there. So people just, for right or wrong, went ahead and just got vaccinated and believed in the system. Now we have so many detractors from just trying to look at the common cause and the common good of these things that, we're having trouble getting as many shots in arms as we want to. If we had this sort of access to superfluous data and superfluous studies back then, we would probably still be dealing with polio now. But it was kind of a different climate we live in. So really vetting that information out, I call it, truth versus trash, is more difficult than it sounds, because we're all inundated with social media and, people blurting out some blurb here and there, and, it just becomes fact. But right now we have a little over 200 million people in America that at least have the first shot in their arm. And that's, I think the US population is right around 330 million right now. So that's around 60% at least have one shot in their arm. And I think we've seen a bigger surge since the Delta variant has come out. So we're seeing a lot more of that, a lot more people seeing, unfortunately, the ramifications of not being vaccinated. I'll tell you, here in Central Texas, and I think this number, it can be extrapolated nationwide as well, is that 98% of people in the hospital are unvaccinated right now. As someone who is following this closely with our group, we, as a group, we treat thousands of patients on a day-to-day basis. And we've only had 2 that have been hospitalized that were double vaccinated from the new variant. And both of those people were extremely, extremely ill. They had a lot of comorbidities, a lot of lung dysfunction, et cetera, which led to their hospitalization. But for the most part, what we're seeing with this Delta variant is, luckily, our vaccinated elders are able to recover. It's presenting more like a regular flu, or 7-day kind of, illness with fever and cough, et cetera, but we're not seeing the massive immune response that we were with the earlier unvaccinated round of major COVID infections. So how do we know it's the Delta? I hear that a lot. I don't know if anybody's asked you that. How do we know I've got Delta versus the other? We don't really. It's an assumption made based on epidemiological studies. So what they do is the hospitals are able to do this in a few clinics out there. They will take random sampling over time. When we see a massive resurgence like this, they'll take random sampling of positive COVID patients, and they can do a genetic mapping of that and see if it is the Delta variant. And almost every one of them over the past 2 or 3 months have been the Delta variant. So it's assumed that everything you're seeing now is greater than 95% is the Delta variant out there. So do we really care? Do I care if you have the Delta, the Alpha, the Lambda, or whichever? No, our treatment course is the same. And it's all really, like I said, based on whether you have received, your vaccinations or not at this point. So does that make sense? So it really doesn't matter to us, but the general thinking is it is Delta that we're seeing out there.
Ryan,
Yes,
I
ma'am.
have a question.
Sure.
I'm not too informed. Like I said, I'm a parent support specialist.
Sure.
So I get a lot of questions from our parents in regards to the infusion monoclonal. And can you elaborate a little bit on that, maybe 2-3 minutes? For example, my daughter did not get the vaccine. She's 24 and she got infected. Thank God she was only at home for a week and a half. And one of my neighbors said she should have gotten the infusion, and I hear also, like when the president got infected, Trump, he got the infusion. What is that and who can get that? Can you elaborate on that?
So anyone can get it now, and we're having monoclonal antibody infusion centers pop up around the city. There are several dedicated now to that. And I'll send Lynn and Dura some information on those, and they can get those back out to y'all. So we are currently sending our elderly patients in facilities and our home patients to these clinics to get the monoclonal antibody infusions. And in a nutshell, without deep diving into what monoclonal antibodies really are, it's basically another tool we have to fortify our body's defenses and our immunities to recognize the virus and to reduce the inflammation associated with it. It's another recipe we're adding into the mix. So we're doing that, and we are still using dexamethasone, which is a corticosteroid. And again, the purpose of that is usually a 5 or 6 day course. We're using that to reduce inflammation. These are all about your body's inflammatory responses. As far as where, we're talking about some of the trust versus trash, there are a couple of sites that again, I stay off the news sites. I just think whether it's CNN, Fox News, whatever your bent is, it's going to be skewed in one form or another. Obviously, cdc.gov is a great site. It's just going to be data, and it's, scientists just giving data. There's no big pharma behind it pushing their motives. The World Health Organization is another one. It's who.int. Again, government sites, government run, no bias. But my favorite of all is it's called getvaccineanswers.org. I'll say that again, getvaccineanswers.org. and that is actually the Ad Council, which is another nonprofit. The Ad Council is actually run by media organizations, but it's strictly regulated as far as its bias. Ad Council are the ones who did the Smokey the Bear campaign and, you know, the Mothers Against Drunk Driving campaign. So it's just a lot of data, but it's a very intuitive site, very easy to use, lots of quick little flashcards about, you know, quick answers to questions we're seeing out there right now. So I'd highly recommend, you know, if you don't want to get mired down in the verbiage of science, try those sites, especially the getvaccineanswers.org. And one other thing, people always ask, hey, well, it's not FDA approved. Well, the Pfizer vaccine is FDA approved as of this week. And one rebuttal I've heard several times is, well, they rushed it through. Well, no, they didn't rush it through, which is why it's August 2021 and we're just now getting the results. They did complete the approval process faster, and it was about 40% faster than normal. They did not skip any steps, but what they did was they would overlap some of the testing steps. There's a very discrete stepwise fashion that the FDA uses to approve a medication or a new treatment. And so what we do, or what they do during the emergency use authorization, is they wipe everything else off the table and say, we're going to put this other obscure vaccine, you know, approval to the side for now, and we're only going to focus on this. So while one department is working on this piece of approval, another one is concurrently working on a different piece of it. So they're overlapping, so we're able to speed it through. But no steps were skipped or bypassed in any way, shape, or form. Let's see, what other questions are y'all hearing right now, or comments out there?
Okay, I have another one.
Sure.
Is it because we've only known about coronavirus, this particular one, and COVID-19, you know, less than a couple of years,
Yes,
at
ma'am.
least publicly anyway? Are there any intelligent and informed estimate or speculation by those who really know and understand this COVID-19 thing about the future, how it would affect the body in the long term, let's say 5 years from now? And some of us, me included, is like, I'm just wondering, you know, can we expect, I know we don't have a magic crystal ball, I understand that. But given the experience and expertise by the scientists, medical profession, do you expect the vaccines that have been given to have any kind of long-term effect on the body, let's say, like I said, some years from now?
So, you know, we really don't have the data to truly answer that, you know, 100%. I can tell you, based on the vaccines that we are using, there's no inclination that would be an issue moving forward. Obviously, the Johnson & Johnsons are what we call traditional vaccines, correct? So their mechanism of delivery is the same as the flu shot and everything else. And, you know, for the most part, most people have zero lingering effects from taking a vaccine, whether it's measles, mumps, rubella, influenza, shingles vax, pneumovax, etc. Now, everyone kind of gets stirred up about the whole mRNA thing associated with, you know, the Pfizer and Moderna vaccines. But if you keep in mind, if you really know anything about the bioscience of DNA and RNA, they're just blueprints. You don't get COVID from an mRNA vaccine. All it is, it's a piece of data. It's a protein that we introduce into your body. It's like a cookbook. It teaches your body how to recognize the outside of the coronavirus. That's all it does. You know, people are used to some of these older vaccines, and especially when we started with flu mist, which was the flu, instead of the shot, it was the mist people would use in their nose. I think that did a huge disservice to the vaccine world because it is a live virus. And if you sneeze or your nose drips and you rub your eye, you will get the flu from flu mist. I mean, it happens, you know, it's been proven to happen. Regular vaccines are what are called dead or attenuated viruses. So the virus is either extremely weakened or dead to where it can't infect you. But these, from the standpoint you're talking about, Lynn, there's no viral component to it. It's just a map of the body to use to make a protein. So that being said, I don't see any long-term effects from it. It's not entering your DNA. It doesn't even go into the nucleus or the center of the cell where DNA is contained. It goes toward the outside of the cell. So it's used as a recognition piece.
All right.
And I never answered your earlier question, Lynn, about a caregiver living with someone who has a COVID infection. We've seen that quite a bit, especially at the beginning of COVID. We had a lot of residents who had roommates, and one would have it and one did not. And what I can tell you is the best plan that we've come up with so far is continue what you're doing. You quarantine or stay with that person. Just use precautions. Don't touch your face. Keep your mask on. Masks are everything. I know that's a hotly debated thing right now too, but from a medical standpoint, this is a respiratory transmitted virus. Wear your mask. Okay, wear your mask. Wear your mask.
Yes. Thank you. Okay, Aida.
Hi.
Yes. Hi. My father is 91 years old, and I really had a problem getting my sisters on board with getting my father vaccinated. First of all, a couple of them are anti-vaxxers, and one of them is in the hospital with COVID, unvaccinated, because she didn't believe in the vaccine.
Yeah.
So anyway, their argument was that, oh, our dad's too old. He wouldn't be able to take the side effects, you know. Oh, but my father only has one lung because he had tuberculosis as a young man. So he only has one working lung, and it terrifies me that he could possibly get COVID, you know, at 91 years old. He has Alzheimer's too. So is there ever a situation where someone is too old to get the vaccine?
No, thank you, Aida. That is a wonderful question and right in my wheelhouse. Absolutely not. I will tell you, your father should be first in line to get the vaccine. He is immunocompromised. He has Parkinson's. Does he have a dementia component with his Parkinson's?
No, he has Alzheimer's.
Okay. Oh, I'm sorry, Alzheimer's. Okay, he does have Alzheimer's. I'm sorry.
And he does have dementia. He doesn't know who I am. I go to visit him.
He's not going to be able to practice good safety hygiene measures anyway. But having one lung, his risk of severe illness is huge. And no, there's no age too old. I've had 103-year-old patients get it. And honestly, the younger people like our generation here are the ones who have more side effects from the vaccine because we're able to produce an immune response. Older people don't have an immunity that's strong enough to produce an overwhelming response. So most of our patients had zero effects, where I was personally sick for 2 or 3 days after I got it, which is good. We want you to have that response when you're younger. That shows your immune system is responding to what we're doing to it. But the elderly do not have that. And I will tell you, Ida, I lost a lot of patients. I had one small building. Dura is familiar with the one I'm talking about. There was 20 patients in the building. None of them were vaccinated. People weren't wearing their masks. We lost 12 in 1 week.
Wow.
And they were all elderly dementia patients. Couldn't isolate them, couldn't keep them away from each other, and it spread like wildfire. The entire building, 19 of 20 got it, and 12 of them died within 1 week.
Wow. Now, he did end up getting the J&J, which is better than nothing.
Absolutely.
And the doctor suggested that one because he does have some allergies to certain medications.
Sure.
And he was afraid that maybe he would have a reaction. Now, this was about 6 months ago. So he's due for a booster, right? So now I've got to fight with my sisters again, you know, to try to get him in to get a booster.
Yeah, and so the boosters will come out the 3rd week of September. They're still trying to figure out how to roll that out with what the production, rollout's going to look like on that. But usually they want you to wait about 8 months from your original to your booster. So
My doctor already gave me my booster, and it was 6 months from my
That's fine.
last.
Yeah.
So
yeah,
yeah.
CDC
Actually,
said-
Walgreens and CVS are already giving the boosters.
And I will tell you, I'm going to wait a little bit. I've had my blood drawn to see if I'm still making antibodies, and I still have a really high antibody response. I received my vaccine in December 2020. So,
Wow.
yeah, I've had mine for a long while now.
Now, is that a blood test you can get from your doctor? If
Absolutely. You can go to CPL or have your doctor draw. It's called a titer, T-I-T-E-R. And all that means is a fancy word that just means what is your level of antibodies you're still producing right now. So my personal thought is I wanted to check, so I did it. I'm in a study. I'm in a research study, seeing how long the antibodies are lasting. So they're checking mine anyway. But I'm not going to go get a second shot until I need it. That being said, a lot of people don't have access to it. If you're able to go get it, it's not going to hurt.
I figure better safe than sorry.
Yeah, I'm just trying to wait until my numbers start to drop so that I don't get it too soon and then have to get it sooner the next time. I do think this will eventually be a yearly thing, sort of like the flu shot, just because not enough people are truly vaccinated to get that herd immunity we need to keep this out of our communities. So I think this is here to stay, honestly. And we've been lucky thus far that it hasn't been more deadly than it is. It is to our elderly, but to the general population, it hasn't been as deadly. But I do think it'll be something we'll have an annual booster, if not, buy-in.
All right.
Ryan, is the booster just another one of the same shot, or is it something different?
Good question, Dura. It's exactly the same. It's just like a third shot, basically.
Okay.
If you've received a Pfizer vaccine, can you get a Moderna?
Yeah.
It has to be the same kind that
It does, it goes back to what we were saying about that little piece of mRNA. It's a cook recipe. It's a recipe for teaching your body how to recognize the proteins on this. And the Moderna recipe is not exactly the same as the Pfizer. So you want to make sure that the body is getting the same data each time to recognize the virus.
And this may or may not be a fair question, Ryan, but out of the vaccines that are available right now, do you believe more strongly of one than over another?
I hear people. I had someone tell me the other day that Pfizer and Moderna were the BMWs, and Johnson & Johnson was a Cadillac. I'm like, what does that even mean? People come up with this stuff. Any shot in your arm is a good shot. From a data standpoint, the Pfizer and Moderna have a little bit better efficacy. They're at about 91 to 95% efficacious in preventing infection. But the Johnson & Johnson is 76%. That's great. As researchers, what we strive for is just 50%. We want it to be 50% effective, which is what the flu shot is, or less every year. Just so you know, on a great year, the flu shot, Michael, you probably know this too, the flu shot is maybe 50% effective on a good year. So great question. No, there's no, what we're really looking at now is lessening the effects. And the Johnson & Johnson lessens the effects at roughly the same amount that the Pfizer and Moderna do. So whichever one you can get in front of, get it. I didn't care when they offered it to me. I said, give me one, give me all three. I don't care. I want them. I'm seeing this too much every day.
And are they all free to the public, or how is that?
Yes, absolutely. They're all quote unquote free. You're not going to be charged anywhere for a COVID vaccine.
Are the tests free as well?
Well, no, it depends on which test too. Some facilities are offering, like for our residents, the tests are free. The rapid test. If you're doing what's called a PCR test, which is a little bit more sensitive to actually seeing whether or not you have COVID virus or not. There is some cost to that. It depends on your insurance. It depends on, you know, why you're getting tested. If you're just getting tested like us, we get tested all the time. There is a little bit of a cost, but depending on your insurance company, a lot of them aren't charging anything.
Mm-hmm. Okay.
Yes, Ryan, I have another question. I also get questions from parents about when the booster comes, if you do not have the first and the second dose of either Moderna or Pfizer, can you just go ahead and take the booster?
It would be considered your first shot in the series. They're going to consider it a series, but yes, the booster is the same dose, the same strength, and the same makeup as the others. So it would just be considered your first dose instead of a booster.
Okay, and another question is, so I had the Moderna vaccine already. Do I still need my flu shot?
Yes, they're totally separate.
Yes.
And I'm glad you brought that up, Sonia. I was actually speaking with a pharmacy yesterday, and they were telling me, well, we're gonna, for our buildings, we're trying to collaborate when we're doing our flu shot for the year. It's about that time, and how we're gonna navigate giving the booster. And they said, well, we're just probably gonna give them at the same time. And I said, no, let's don't do that. You know, we always want to separate them just for clarity, if nothing else. It's like starting two medications at the same time. If you don't have to, you don't do it because you don't know what's causing what side effects, right?
Yeah.
But like I was telling the pharmacist, I don't give my dogs all their vaccines at the same time. I space them out. Let's do that with our humans too, you know?
Yes.
And the reason being not something sinister going on, but you don't want to overwhelm your body with an immune response to too many different things, because it sometimes will lead to a less than optimal immunity in the long run if you put too many things in at once. So totally separate than the flu, separate it by at least 2 weeks. And that's how we're going to proceed on our end.
Thank you, Ryan.
You're welcome.
I have another question.
Sure.
I'm sorry, but I do.
Good.
Is there anything that we can do? Like, we've been fighting COVID from the outside, hygiene and all that, and the shots and all that. So is there any, and I've asked this before, is there any way that we can build up our own immunity by either eating properly or exercising, or how can we make our bodies stronger to fight this, in addition to all the outside things that we're doing to avoid COVID?
And you just answered it, Lynn, right there. You know, eating right, getting enough sleep every night, watching your weight. You know, alcohol consumption went way through the roof when COVID started. And, you know, smoking and you know, alcohol abuse can definitely lower your immune system. And it's all about that immunity, right? Everything we can do to promote better health and better living on a day-to-day basis is going to make you stronger to fight not only COVID, but the flu, pneumonias, everything like that. Get out and exercise every day, get some sunlight on your skin. I know I'm bad about that. I don't get out and get enough sun every day. I know we all try to avoid the sun for skin cancers, et cetera, but 10 minutes a day is an excellent thing.
All right, wonderful, thank you. We try to eat, you know, all the good stuff, healthy, you know, but I just figure I actually have New Year's Eve, yes, I have to have my little champagne.
Sure.
It's almost 2 years that I've gone without wine, and
wow.
Oh my gosh. So, you know, yeah, I thought it was pretty impressive. So yeah, I'm staying away because I did read that alcohol can lower your immunity. I said, I'm going to do everything I can.
Absolutely. And I understand. I mean, I'm right in the middle of the mix. I mean, it's been a very stressful time for everybody, and, you know, people try to cope in every way we can, but just be mindful that, you know, anything we do to lower our immune system is going to predispose us to more infection.
Excellent. Thank you.
You're welcome.
Any other questions, comments? And I know we have Melissa and Brenda. Is that Renee? Yes, hello, welcome. I just wanted to, you know, acknowledge you and thank you for joining us. Anybody else have any other questions?
I do, Lynn, if it's okay, a quick one. I know I came in late and I don't know if he already answered it, but It's a brand, ironically, the brand name is Abbott. But it's you can get it at Walgreens or HEB, but it's a at-home COVID test kit. I wondered how much confidence there is in that. I know it's not the PCR, or yeah, is that what it's called, PCR?
That's a great question. And we actually use those rapid tests by Abbott ourselves. That's what it's the same, it's probably repackaged for home use, but it's the same we use for a rapid test. A rapid test is not as sensitive nor as specific to the COVID virus as the PCR test. But for day-to-day use, that's all we use to. You don't need to go the other route. It's just, you know, you're basically taking on a screening approach versus a diagnostic approach at that point, if that makes sense. It's like, I'm in a breast cancer screen versus a diagnostic, you know, mammogram. Little bit more surface, but quicker and easier and more accessible for all of us. So those are great. They're in the 70% range as far as sensitivity to picking it up. They can have some false positives and negatives, especially if you have a common cold, which is another type of coronavirus. But I just suggest if you have a positive with one of those, do another one. Go ahead and do another one in a day or two, isolate in the meantime, wear your mask, do another one. And if that one's still positive, you may want to go ahead and get a PCR test at your doctor's office or a clinic. But a lot of times we're seeing some false positives with those, so don't freak out too much.
Well, if anybody wants one, they're at Walgreens. I got it through the drive-through window, and it's $24 for a 2 test. I just put it here to have it on hand.
Good.
For my husband and I, in case,
No, that's
especially
a good
if
idea.
in the night you're worrying.
Yeah.
Absolutely.
Yeah, that's really wonderful. Now, can we go back to, you mentioned that the, I don't know if I can even pronounce it, the monoclonal antibody infusions, you said that they're available to anybody can get that. Could we ask a doctor?
Yes. Go ask your PCP, and there's clinics set up all over town for them now for these infusions. We're actually sending a lot of our geriatric patients to go get them. It's an outpatient infusion, takes an hour or so, and they're coming right back. It's real easy to do.
And has it been very successful?
It does. It definitely lessens the symptoms and improves the recovery time significantly. So definitely worth doing it. And insurance covers most of them. Again, everybody's insurance is a little different, but it is covered quite frequently. We're actually, for those of you who have relatives in, you know, post-acute settings, skilled nursing, assisted living, independent living, we're actually partnering with several home health companies in town who are going to start going out into the communities and administering the monoclonal antibody infusions also.
Wow, wonderful.
Yeah. So they're that effective and that important that we're using them at that level, scaling it up.
Okay, wonderful. Okay, anybody else have any other questions? Yeah.
Ryan, so on that, on the infusion, if a person has not gotten their vaccines, can they still have it, put it on? Even though, even if they had COVID or not?
Have the infusions? Yes, ma'am.
Okay, thank you.
Yeah. Well, you gotta have COVID to get the infusion. But you don't have to necessarily be vaccinated to get the infusion.
Okay.
Does that make sense?
Yeah, thank you.
Also, we hear a lot of the cases, we hear a lot of deaths and numbers. And I mean, I can subtract, you know, but are most people recovering from COVID-19? Because it seems to me, I mean, one death is too many, you know, obviously,
Absolutely.
but I mean, it's like those numbers, the deaths, I mean, it's kind of a scary number because they're big, but it kind of can skew our view. I'm not diminishing the importance in, you know, COVID, but we've got to have a little bit of hope, you know. So are most people recovering from COVID? Yes,
and you know, I hate even talking about those numbers because they're so manipulated by the news media and by whatever political bent is wanting to prove a certain point. The numbers are very low nationwide and across all age groups for deaths, right? And people are saying, oh, it's lower than the flu, whatever. In our population and the population I deal with, that number is tremendously higher. I think nationwide it's 1 or 2%, something like that is really, really low, right? In the geriatric population, especially in geriatric patients who are in a facility of one form or another, from unvaccinated.
Uh-oh, he froze. He froze on my screen. Is he frozen?
Vaccinated
Yeah.
Mortality rates. It really has affected our vulnerable population at a much higher rate than the rest of the nation. So yes, there's hope. It's the virus, you know, it's not, I'm not making it out to be some big bad monster, but it's a very deadly thing we deal with. Very, very deadly. And from a medical standpoint, the risk of the vaccine is extremely low compared to the risk of what I see on a daily basis in our geriatric patients.
Right, okay. All right, I'm gonna ask one last question and then we'll have to let Dura come on and talk about what comes after, you know, somebody gets COVID or maybe during. But your opinion on how we can increase the rate of vaccinations. I keep hearing about certain communities having, you know, lower rates of vaccination. If you were in charge of the whole shebang, what do you see as that needs to happen?
Oof, that's a good question. First of all, nobody wants me in charge of anything, including my wife.
Oh, I'll be in charge. I'll get this show on the road.
I think it's education. You know, I really do. 98% of the medical population in America are vaccinated. And I think that says a lot because we strip a lot of the biases out of it and we're looking at data. We're used to looking at good data, like Michael was talking about earlier, peer-reviewed data, and trusting the science. Somewhere along the way, there's become this massive distrust of science as well, which is kind of, I mean, you know, I don't know how we got here or how you get out of here, but I think it's just continuing the education piece. You know, I'm not judgmental. If people have reasons for not getting it, that's up to them. But if they ever want to hear or learn from a medical perspective about it, I'm happy to teach them, you know, and I think that's how we all have to approach it. Respect each other's personal values and opinions, but be there and be willing to get that information out for anyone who wants it. And it's just, you know, it's going to be a battle of attrition over time, you know, to see who can get that information out the most.
So
good, correct information.
Thank you, Ryan. Just to reiterate, reliable sources of information would be cdc.gov, who.int, I think is what you said.
Yes, ma'am.
The World Health Organization, and getvaccineanswers.org.
Yes.
So reliable, and you know, I mean, I'm married to a research guy who questions everything, and he has proof.
Yeah.
For everything you say, back it up, you know, and I'm like, that's kind of how we need to be right now.
Absolutely.
You know, and one of the things in caregiving, it also applies way before COVID, is that a lot of people pass off opinion as if it were a fact.
Yep.
So I now ask, and where did you get that information?
Yeah.
You know, was it from your neighbor? Or was it from, you know, NIH? Or because people love to give advice.
You're so right, Lynn. And it goes back to what Michael was saying about, you know, vetting the source of information. And that getvaccineanswers.org, they actually have a flow chart of how to vet information from your neighbors, like you're talking about. It tells you questions to ask them so you can quickly funnel down and see where this information came from and how valid it probably is not.
Excellent. Thank you so much. And I think that also as a double hat of advocates, as family caregivers and individuals, of course, is that we can pass along reliable information, and we can be very helpful to others to help educate. Absolutely. You know, the general public. and it just it's a matter of, family, friends, just in conversation.
Yeah.
But I'm just appalled of my husband was going over all these, conspiracy theories last night. You're kidding. How can people believe? But anyway, yeah, reliable information. All right. Well, unless anybody else has a comment or question, I'm going to thank you, Ryan, for your time. It's been invaluable. And please keep us updated. Put in you have my email address, and of course, I'm sure you have Dura's. Any updates on anything, or if you want to come back and let us know some more, we'd love to have you. Thank you so much.
You're very welcome. Yeah, thank you for having me. And I'm gonna put these links in an email to you two, and then feel free to share my email with anyone who has any questions. They want to contact me directly. I'm happy to continue the conversation.
Wonderful. Did you put in your contact info on the chat already?
I haven't. I'm not very smart about Zoom.
Okay, all right. So
maybe
if
Dura, you know how to put my email on there?
I can.
Okay.
Yeah, and you know what? I will add it to our follow-up email to all the Caregiving Cafe caregivers, if that's all right with you.
Absolutely,
right?
absolutely.
Thank you so much, and you stay well.
Thanks, guys. Y'all too. Have a good day.
Ryan.
Bye.
Bye-bye.
All right, okay, so if Melissa or Brenda or Susanna are available to say hello, we are ready to say hello. Otherwise, we will continue on with the show. I just want to say hello, Renee. I'm glad you made it. Now we will take turn the floor over to Dura, who's going to talk to us about grief and loss during and after caregiving. We may not realize that we experience some of those things, in life in general, but especially in caregiving, not just at the end of life. So anyway, thank you, Dura, and it's all yours.
All right. Hi, everybody. So for those of you that don't know me, I am Dura Sims, and I'm a care navigator with Heart Hospice and Palliative Care. And we obviously provide end-of-life care. Although that being said, end of life is kind of a scary concept, right? End of life care just means that you have a diagnosis that is a terminal diagnosis, but it does not necessarily dictate when you're going to pass, but it does give you empowerment and control over the events that occur prior to someone's passing. So hospice is a wonderful thing that can really empower a person to take control of the narrative of how their story ends versus it being finished for them in a hospital or transport to a hospital. And palliative care for True Heart is simply a social service. It is free, and it is provided for people who have one or more illnesses that are terminal, but doesn't mean that they are terminal. And they have a barrier to care. They get a dedicated social worker to help meet needs from anything from food insecurity to building ramps to applying for Medicare, Medicaid, whatever your needs are, we assist with that. I do have my information in the chat. So if you feel like you have questions, you want to talk about those options, feel free to reach out to me. So I am going to share my screen, and I'm going to start with a quick video on grief. And then, well, where did it go? It looks like it went out of there. Hold on here. See if I can get over to my video that I want to share with you guys. Caregiving. It logged me out of it. So give me a second, guys, and I want to get to the video. So before I do that, we'll start here. Let me see if I can get into, give me 1 second. Let me get into my emails real quick so I can click on this video that I want to share with you. For some reason, YouTube logged me out. Move this out of the way. Can you hear me?
Yes.
Oh, okay, I thought you were talking for a second there, Lynn. Let me get over to the video that I want to play for you guys.
If I may, while Dura is setting up, because I know she'll get it, just very briefly wanted to let everybody know that I'm working with a couple of groups and save the date for on Saturday, October 23rd of this year. It'll be an all-day virtual event and small in-person in Dripping Springs event, but mostly on Zoom. Thanks to Heart Hospice, who is going to be the technology sponsor. And it is going to be about end of life information, but it will be as it presented as a celebration of life. It will be called Mindful Remembrance and Ofrendas. So we want you to be interested in finding out what ofrendas are. So you gotta be there to find out. But it's going to be a culturally engaging and enriching event that will focus on end of life. Like I said, as a celebration and what you need to make it a good death, a good celebration of the living. So more information will be coming in the near future.
All right. Now, thank you, Lynn. I'm going to do a full screen on this real quick. So hopefully that'll pull this up. And we're going to just watch a quick video, and then we'll go through some of the slides that I put together addressing dealing with grief when so much is happening in your day. And really, we live in a world right now that is so sensory overdrive. And regardless of whether we're caregivers taking care of somebody, whether we're trying to take care of ourselves, or whether we have lost somebody recently and we're coping with that, life is still happening around us, and it's happening very quickly. And it's very challenging to cope with all of the other things going on, as well as the grief that we can sometimes feel from being caregivers. So we're going to listen to this, and then we'll have a conversation on it. Can everybody see this?
Yes. I can't hear it.
Okay, hang on one second.
I can't either.
All right, hang on one second then. Let me go back real quick to my share, and let's go to share sound. Okay, I'm gonna start this over. Sorry, I apologize.
That's all right.
Today, Dr. Ashley
now?
Bryant and Cynthia
Good.
Stafford share strategies for processing grief with so much happening in your day. This Polaris video was made possible by the American Nurses Foundation.
One of the first principles I'd like to discuss today is about acknowledging the loss. And I'm about to read to you a journal entry from a widow. And this is 6 months into her grief work from the loss of her husband. I'm learning that the best way to get to the other side is to go through it, to face it and to name it, to accept the pain and deal with it as directly as I can. I'm also finding, to my surprise, that there are frequent stretches of days without tears, and any feelings of despair have been only fleeting.
It's important to make sure as a healthcare clinician that we acknowledge the loss to that patient's family. We know that this is a difficult time for them. And one thing that oftentimes patients, family members come back and share with us was that no one even acknowledged that my loved one died and how special they were to me. So let's continue to move forward with making sure that we acknowledge the loss of the loved one. I would say the second one would be being able to allow the caregiver to express themselves in their emotions, however that may be for that individual. I also think it's important for us to think of the cultural component of that, that different people express themselves differently, and being open and non-judgmental in how someone expresses themselves is particularly important as healthcare providers. I also think exploring with that individual what works for them. And so respecting that and being there to listen is key.
My thoughts are another principle is that it's really important to use rituals to remember who that person was and also who that person continues to be to me. Centuries ago, when a loved one died, women would wear black and men would wear black armbands to remind those around them that they were in the process of grief. I have a colleague that's working through grief of the loss of a parent. There's a lot of people walking around every day that are in the process of grief, and she would like to know who they are so that she could reach out with more understanding. There are other things that we can do, such as letting those balloons go with people that we love. It really is in community that we begin to heal, where that person walks beside me as I grieve, or I'm walking beside somebody else as they grieve.
And how we are grieving when this is all happening. Steady lives are happening. We're still having to pay bills. You may be a caregiver of children or of adult parents, and being able to allow yourself that opportunity and the time to grieve. That's important.
You had that wonderful article about PACE, and the P stands for presence. And I think that's very important, that we're just present and mindful about our grief.
A, which is active listening. So being an active listener when someone is talking with you, that means being fully present. Your pager or your cell phone may be going off, but allowing yourself to really be an active listener with that person. And C is compassion. We must have compassion for those who have lost someone, and we must have compassion for ourselves as well.
Yeah.
And lastly is E, which means being empathetic. That means oftentimes we're taking on those emotions and those feelings of what someone else is experiencing. And oftentimes we're experiencing it as well, but we may not externally express that in tears or with crying or with moaning, whatever that may be for you. So I think it's important as we think of PACE, P-A-C-E, we have to really pace ourselves as clinicians, but also making sure we're present, we're active listeners, we're compassionate, and we're empathetic.
We hope you enjoyed this discussion. To learn more, download our resources.
All right, so let me go back over here now, and I want to share our oh, hang on, let me go back and clear that out real quick. Turn that off. Okay, let me get out of that and come back in here, and now we'll get to our presentation. So share screen and my PowerPoint. And can everybody see that?
Yes.
Okay.
Yeah.
So the video was obviously geared towards medical professionals, but it's important to know that whether we are caregivers at home with our loved ones or medical caregivers, we experience grief. So that was an important video to me because it really does cross over all lines and all barriers, right? So what is grief? Grief is simply a response to a loss, particularly of somebody that you care for or that you really love. And grief can have an emotional, a physical, cognitive, behavioral, social, cultural, spiritual, and philosophical dimensions to it. And loss can be felt during the caregiving process. So while somebody is alive and you're taking care of them, they've experienced an illness, whether that person is a spouse or whether you're a child taking care of your parent now, whatever the situation is, it is a process of losing the healthy person that they once were. So you can experience loss while somebody is still living and their diagnosis, whatever that diagnosis is progressing, and they're getting closer to end of life. And then you experience loss as they get at there and reach end of life. And both are profoundly different. So is the difference between taking care of a parent versus taking care of a spouse or a loved one. And So you have to recognize that it's very important that we have compassion and understanding when we're helping somebody or ourselves cope with those losses. It's okay to express your feelings and it's okay to talk about them. A lot of times people feel like they have to hold it inside or they have to be strong for someone else. And the reality is, if you're not taking care of yourself and you're not getting those emotions out in some way with the trusted person, whether that's a therapist, a best friend, journaling, however it is that you get those feelings out, if you're not taking care of yourself, you really can't be the best caregiver or the best provider for someone else. And then it's recognizing that it's okay during the process of taking care of somebody to experience feelings like anger, sadness, grief, loss, all of those things while you're taking care of them. And then after your loved one has passed away, you're going to experience a state of depression oftentimes, and that's okay too. And it's okay to talk about that because you've gone now from filling your time with your role as a spouse or your role as a child was changed and you became caregiver slash spouse, caregiver slash child. And now you're grieving, and all of that time that you were putting into taking care of the person that you love is now really becoming a part of your core day-to-day event. And what do you do with your time? What do you do with your emotions and your feelings? And so when people are talking to you, people need to remember to be respectful and listen, because oftentimes we want to jump into the saving mode or the fixing mode. And people don't necessarily need to be fixed. They just need somebody that they can listen to or talk to that will help them respond to their grief. The next video, there we go. Okay. Are helpful ways to grieve with someone and work through the process of grief. Community, as the video said, is a very important way to heal. A lot of times, you know, I'm one of those people where I feel like if I'm not happy, it's always my job to help people stay happy and be happy. So if I'm not happy, I withdraw and I don't talk until I'm happy again, so I can keep everybody happy. Well, that's not a great way of dealing with emotions and processing things. The better way is to find community. And sometimes finding that community is seeking people who are experiencing the same experience you are. So if you have a loved one with dementia, if you find others and you go to a support group for dementia, that's important. If you've lost a loved one to cancer or they have cancer. So finding people that are in like situations or similar situations where you realize you're not alone in your grief, you're not alone in what you're going through, and you can help each other heal and get through things that way by walking beside each other as you grieve. You may be a caregiver of an adult parent or spouse, but grief is experienced in different ways and it is different for each relationship. So, you know, sometimes, and we'll get to a slide where I have some of the things not to say versus some of the things to say. A lot of times if we've taken care of a parent and we know somebody who is taking care of their spouse, we want to say, well, I understand, I've been there. Not necessarily. You understand the caregiving process, but it is a very different event when it's a spouse versus a parent. And so recognizing that and becoming an active listener, practicing that pace. And I thought that was really an important way of understanding the importance of talking to somebody. Pace, P, being present and mindful about someone's grief or about your own grief. A, being an active listener. You know, that old analogy, God gave us 2 ears and 1 mouth. It's so true. It's important that when somebody has something to say, we don't stop them and interject our thoughts or our experience necessarily in that moment. Let them talk, let them work through their emotion, and allow yourself, if you're the person speaking because you're grieving, allow yourself to get all those emotions out. And then if you want feedback, ask for the feedback. C is that compassion. Be compassionate in everything, because people, no matter who you are, we're all going through something. Practice compassion daily with anybody that you encounter. And empathy, being empathetic to someone's feel somebody's situation is important. It means not sympathetic. Nobody wants you to say, oh, I'm so sorry for you, or I feel sympathy for you. Empathy is what we're all really looking for. Somebody who can help us through our grieving process and with our emotions. They can take on those emotions and help you get through them. So empathy is very important. Some of the best things to say to somebody in grief are, the 10 best things are, I'm so sorry for your loss. I wish I had the right words, but just know that I care. I don't know how you feel, but I'm here to help in any way that I can. Your loved one will always be in my thoughts and in my prayers, as are you. My favorite memory of your loved one is, it's wonderful when you can share good memories and hear other people share good memories of your loved one. I'm always just a phone call away, letting them know, reassuring them that it's not a burden and that you'll be happy to be there. Give a hug instead of saying something. Sometimes people just need you to sit with them and be a shoulder, be an ear, be a support. So you don't necessarily always have to have something to say, and that's okay. And then we will all need help at times, and I want you to know that I'm here for you. It's acknowledging and giving them permission to accept that what they're feeling is normal, that it is okay to share that, and it is okay to ask for help. People are more inclined to reach out when they know that you're not being judged. And I'm usually up early or late. If there's anything that you need, don't feel bad about reaching out to me, and say nothing, just be with the person. 10 worst things that you can say to somebody in grief are the things you would want to avoid saying. And believe it or not, these are things that have actually been heard and said. You're going to hear some of these and go, whoa, who would say that? It's been said. At least she lived a long life. Many people die young. While we have good intentions when we say that, it doesn't necessarily help the person grieving. It sometimes is like, well, yes, but that doesn't change my grief. He's in a better place. He may very well be, but sometimes when you're grieving, your expression or your feeling is, no, the better place is here with me. So I can't jump on board with that statement. She brought this on herself. Judgment. Don't practice judgment. Help somebody through their grief. There's a reason for everything. Okay. Aren't you over him yet? He's been dead for a while. That's been said, believe it or not. You will find someone new. While that may be true, and it may help somebody at some point, it isn't necessarily the thing you want to hear right now. And it might not even be something you want to do. So avoid those positive things that might not really actually feel good to the person. She was such a good person. God wanted her with him now. I know how you feel. Not necessarily. You might have experienced something, but you don't know how they feel. Let them tell you how they feel. She did what she came here to do, and it was her time to go. And then lastly, be strong. Why? Why do you have to be strong? You don't necessarily have to be strong. And it's okay to fall apart. It is okay to cry. It is okay to grieve. So be strong is not always the most helpful thing you can say to someone. I'm going to skip over this one. So traits. What are some of the best traits that you can find in a person that is trying to help somebody grieve? Being supportive and not trying to fix the situation. Talking about feelings. Non-active, not telling anyone what to do, but allowing them to work through the grieving process. Admitting that you can't make it better, but you're there for them. Not asking for something or someone to change their feelings. Recognizing that they're going through a loss, and there's not a time limit. My father passed away over 20 years ago, and I still grieve daily. There's not a time limit to loss. There's not time limit to grief. When somebody needs you, be there. Traits to avoid. They want to fix the loss. They're about our discomfort. They want to direct, or they are directive in nature. So telling you how to get better, telling you what to do. They rationalize and try to explain the loss. They may be judgmental. They may minimize the loss, or they may put a timeline on the loss. There are 5 stages of grief. I'm not going to read them all to you. I will just go through them very quickly because I know we do want to get to the support group part of this. If you have questions, feel free to ask. But the 5 stages of grief are denial. So whether that's when you first get diagnosed with something or after somebody has passed away, you first experience denial. It didn't happen. It's not happening. Anger. You finally get to that point where you're mad at the disease. You might be mad at the doctor. You might be mad at the person for leaving you or getting sick. Bargaining. You might find yourself bargaining with God or bargaining with yourself or the person. Just if you just give me one more day, I'll be better. I'll do this. And then depression. Depression seeps in on a number of different levels. And then lastly, there's acceptance. And that's really where you put a framework around what's happened. And you don't forget the person, but you accept what has happened. And it's just important to remember that grief is unique to everybody. And we don't all experience it in the same way. So I'm going to skip through these because this just talks about what denial is, talks about what anger is. I gave just a brief synopsis of each, how you can bargain, depression, acceptance. And there is sometimes considered a 6th stage of grief, and that's finding meaning. Just like in life where we need to have meaning and purpose, we need to find meaning and purpose in somebody's life that has passed away. And that can be the same thing with dementia, because dementia is a series of passings, right? They lose something every period where there's a change in the progression of their diagnosis. And so helping to find meaning in that will really make the acceptance come a little bit easier. And illness creates the need for the caregiver to be a caregiver for someone you love, and death removes the burden or responsibility, but leaves a big void. Grieving is a natural part of both processes, and you need to give yourself the grace to get through both stages. Don't ever be afraid to seek help or ask for support from a support group, from a therapist, from a doctor, from your family, clergy, anybody. So that is it for my presentation. I'm going to stop the share and get back over with you guys. And if y'all have any questions for me, I'm happy to answer.
I won't be the first one to jump with questions, so please ask.
Did y'all find that helpful at all, or did y'all find that you experienced some of those things in your own loss?
I found that very, very helpful. I lost my father in November. He was 97. He just faded away at home. And all of that was what I heard. And I wanted to just scream at them, don't tell me he's in a better place, don't tell me this, and don't tell me he lived a long life. I know that, but yes, that's what you hear. And I loved your presentation. I am going to try to get your information. I would like to have that presented to my parents in Spanish, because we have a lot of that here in Austin. So I love it. I love it. I am very touched with your presentation. Thank you so much.
Thank you. And we do record, this is all being recorded. We can send this out in English. But Lynn, right now, why don't you touch on what we're working towards if you want to, since the conversation in Spanish just came up?
Yes. Okay. So first of all, I am bilingual, so I can translate things. But we, and I'm so glad that you like the presentation. That I did as well. And let me just point out that, and remind everybody that in caregiving, we, like Dura said towards the beginning, we experience losses, and it's not necessarily experiencing your loved one's death or being there. Hopefully we don't experience, but we grieve the loss of the person, the healthy person, the healthy version of the person that we see now. you know, and Dura also pointed out that it's very different when it's your spouse or when it's your parent or when it's your child or a sibling. They're all different relationships. So because they're different relationships, it's a different kind of loss. So so anyway, they have common grounds, but also very different. It feels different. So I'm going to touch on the mindful remembrance and Ofrendas. We changed the working title, so but it's going to be kind of like a pre-Dia de los Muertos celebration, which is a celebration of life and to remember the person that has now passed. And in the lady, Laura Zarate, is a family caregiver for her husband, but also she is from Mexico and wants to pass along this tradition. I know I did not grow up with that tradition. I am from El Salvador. I mean, American, but was born in El Salvador. So I did not go through that. So it's all new to me. And I was telling, I think Dura and Laura as well, that we hear about Dia de los Muertos happy hours and concerts and whatever, but what is it? You know, so, and what are the festivities, if it's a festivity? So anyway, so Laura approached me last week and said, let's do an event which will focus on end of life, but really a celebration of life. And we will explain what the ofrendas are about. What are they, what the significance and relevance is, but also make it an online event for end of life issues and resources and information. And it's going to be fabulous. I'm very excited about it. Laura has experience organizing conventions from local, and she's in Dripping Springs at the moment, to national conventions. So my husband also has organized national and international conventions. So we're pulling all of our expertise together to bring this to our community here in Austin. And like I said, it's going to be virtual first, but it's going to be both culturally relevant and engaging. And so we're going to explain about the Dia de los Muertos traditions, but also we will have presentations by professionals talking about grief, loss, hospice, palliative care, end of life issues that surface, like legal and financial planning, traditional burials, non-traditional burials, such as green burials, so we can educate ourselves on these topics. And then we can make better choices because they will be informed, but also learn that there are other choices besides the little bit that we learned about. I mean, I had no idea about anything, funeral, anything, until my dad died. So then we were scrambling, oh my gosh, what do we need to do? You know, well, we can avoid all of that by looking into learning about these resources and how to do it way before we need it. So we have, as Nancy Walker likes to say from the Funeral Consumers Alliance of Central Texas, get all your ducks in a row. And as a family caregiver, it's a much better place to be when you already have a plan or an idea of what needs to happen and how you're going to do it and with whom. Then when you're in crisis mode, we just can't think very clearly then. So I will keep everybody informed about this event. I know Dura and Heart Hospice will be there participating, and we're very excited about this. So I hope you will make time to attend Saturday, October 23rd. The beauty of it is that if you cannot be there on the day, it will be available on a website that Laura has created. And anyway, it'll be really exciting. So I'll keep you posted on that. So anyway, anybody else or anybody have some questions and comments about grief? I'm particularly interested in the grief that you experience while you're caregiving. Any thoughts or comments on that?
From me or from others?
From anybody who might. I know I have comments, but I don't want to be the, always yakking away. So any comments? How does everybody feel about your process of losing, quote unquote, but perhaps finding someone new or a different version of the person that you're taking care of?
I'd like to make just a quick comment if I can. One of the things you said not to say was be strong. I think that was very difficult for me. Number one, being male, you're supposed to be strong, but being more or less in leadership at work, and my wife and I were very involved in church and we were in leadership. So you kind of have to be strong for other people. And I can remember very early on when I was dealing with this, I had breakfast with a good friend almost every week for a while. And I remember telling him, I thought I was stronger than this because I was not dealing with it very well. And just giving people the freedom to not be strong, even encouraging them not to have to be strong is very important.
That's a really, really important thing that you pointed out, Mike, and I'm proud of you for pointing that out. And yes, men and women are wired differently, and I think that can be a pretty good thing. But strength doesn't always come in this machismo, and
Right.
you can be very strong quietly, and you're actually human too. Men are actually human. So
We
it
are.
is okay.
Sometimes.
Yeah. And it is okay. And I've said this several times. It is okay to be human.
Yeah.
I would not want to be married to a robot, and we can all be kind of that way sometimes when we don't express our emotions the way Dura said in the presentation. And it's, and I find it to be a sign of immense strength when a male actually says, this is hard, or, I'm suffering, or this hurts. I see that in my husband every day. And, he keeps very quiet. So I think it's a sign of strength when you actually face reality and say, you're strong enough to say that something doesn't feel great. It's kind of like a guy wearing a pink shirt back in the day in the 80s. He had to be strong enough to wear pink, and so actually I think that's an admirable quality.
Thank you.
And we're also all programmed differently from the time we're children on. Our narratives that we learn as kids run through our heads the rest of our lives. And so if you were told, boys don't cry, or they don't share, or we're the provider all the time. And sometimes women, I was always told that you don't cry, it's a sign of weakness. So we all, and there, hence I was always the strong, happy person for everybody. It took a lot of events to get me to the place where I realized it's okay for me to be soft in moments, and it's okay for me to be weak in moments and draw on other people's strength. So sometimes it's about deprogramming the messages that we get through our culture, the messages that we get through our youth that are so ingrained in who we are. And once we work through that or decode it, that's where we can really start to reach true acceptance and comfort and be comforted. And we can also in turn be a really great support to others because we don't feel the need to be strong or to tell them they need to be strong.
I think, Dura, that it's very important that with this that you just presented, we reach out the different cultures, because, for example, my parents were Mexicans, I'm Hispanic, right? But I have brothers-in-law that are they're, I don't want to say the wrong words, but they're white, you know? And when people pass, or even when it's a birthday, they go things like, what? It's just another birthday, you know, it's just another number, you know? And when somebody dies, well, he died. We all gotta die, you know? And I feel that we need to get out there and just try to reprogram their mind. And it's okay. They don't need to say anything at all, but don't say those things because they hurt. We have to be very careful with all the different cultures, you know, what are their beliefs, you know, and like you said, say these things or just don't say nothing and hold their hand or something, you know, because it's hard. It is very hard. And I feel that, like, again, I'll say it again, I feel that I am going to be presenting this, you know, several times during the year for my parents. I have all type. I have a Spanish, I have some Asian, you know, and to know that we need to respect everybody's way of grieving. Thank you.
Thank you.
That's very, very well said, Sonia. I know there's an organization called, and I don't know if I'm going to say it correctly, SAIVA, which is actually focusing on South Asian cultural issues. And the lady who organized it is a family caregiver for her mother. And she kind of created that so her mother could become social. She didn't know anybody, you know, she came here from India. And so you mentioned the cultural differences, and yes, they are important to address people in a way that won't be offensive, you know, so very, very pertinent. And I think part of it, when people say, you know, with all the good intentions, they may just say the wrong thing. And it could be that, you know, perhaps they just weren't taught that, or maybe they forgot that, you know, we need to still mind our manners and be considerate of other people. And if people behave the way they drive out there, cutting everybody off and, you know.
Yeah, because I feel they just need to be reminded because like we said, they say the wrong thing at the wrong time when that other person is grieving, and then all this rancor bluffs out, and that's another story. That's another topic. So, you know, just to avoid, be reminded, you know.
You know what? I think you touched on something very important, and I think we're going to add that to our presentations on for the Mindful Remembrance and Ofrendas event, because it's very true, you know. And I always think of, you know, what is it, Thumper? If you have nothing nice to say, don't say anything at all. It's so simple, you know, and it's very important, especially at times, you know, of grief. So thank you for pointing that out. Anybody else?
Yeah, I wanted to say that I'm familiar with the stages of grief, but I was glad that it pointed out that it doesn't necessarily go in that order, because my mom died in April, and I went straight. It took a couple of weeks, and then I just dove straight into depression and some anxiety, and have been stuck there ever since. And finding anger is hard, and any of the other feelings I haven't even gone through. So I just went straight to that stage for whatever reason, and then at the same time grieving the changes in my husband daily. So it just if I don't know how long it can stay stuck there, but boy, it's like my body just it's stuck there, and it's like was for the longest time I wasn't even crying. Like, and I'm a big crybaby. Wasn't crying about my mom. Wasn't crying about all these things. Just it was so flat. Just recently, I've had a couple of cries, not big ones, very short, and that's something. But I feel like a dam needs to, you know, move, and I need to flood with crying and get this moved out and get back but it's like being frozen in this depressed victim state, and it's very hard to function anyway. So that's where I am on the stages of
And
grief.
you may find that there will be at different times triggers that all of a sudden that dam does break, right? And that's the importance of the point that there's not a time frame or a time limit. People think that, okay, it's been 6 months, I should be over this. It's been a year, I should be over this. Like I said, my father passed away over 20 years ago. I almost cry daily. I still, to this day, there's something that will come on. There's a song that will trigger something. And it's okay, because those tears are really a reflection of the love that you felt for that person. And staying in the grief is not always healthy, but experiencing it and recognizing, like you've done, like, this is where I'm at, I feel like I'm plateauing. The more that you talk about it, you're going to realize that there will be something that will be a trigger point for you, and the dam will break and you will cry. And that can happen for decades. For some people, it doesn't happen at all, but it's also very reflective of the nature of the relationship that you had. Even sometimes people always think that those emotions come about only when you had a great relationship with somebody. Sometimes when you've had a tenuous relationship, a stressful relationship, a bad relationship, those emotions, you can even come about stronger, because now it's tied with, did you ever get the chance to say, I'm sorry? Did you ever get the chance to give forgiveness? Those are all important things.
Unresolved. Yeah. Yeah. Unresolved. Yeah. Oof. Yeah. I wish now I could cry. I would feel better to feel something than the empty blah. It's hard to not, because there's no inspiration, then there's no appetite. There's, everything just kind of blah.
And journaling is a great way to understand when you're feeling different things. You said there's times where you almost cried or you did cry. If you're journaling daily, then you can go back and you can take a look and you can see what were the things that brought about more emotion than things that you were just flat and didn't have any emotions at all. And that might help you as well. It might just be a change of scenery, a change of thinking.
So do you mean like writing in a journal every day and just saying, this is how the day felt or didn't feel, or
even multiple times throughout the day? You might be sitting down to eat lunch because you know that you're supposed to eat lunch for healthy purposes. And you might say, I took a bite and I just pushed the plate away because I didn't feel like eating. And then as you write that down, ask yourself, what emotion? Tie an emotion to the event. So I didn't feel like eating. What am I feeling right now? What's that feeling that is correlated with me not eating or binge eating? What's that feeling? When you can start to tie emotions to actions, it helps you understand more about how you're grieving and how you can address those areas that are pain points for you.
That's good. Thank you.
Renee, I with my mother, and she passed 4 years ago in June, there's still this numbness even now. I did not cry when my mother passed either, but I didn't cry when my dad passed either. And I was really surprised. I think I was in some sort of, I'm not medical anything, shock, because it's like, no. And I'm sure that was blatant denial that, no, did that really happen? No, that only happens in movies, And it was, I felt like I was just floating or in a pool. I felt like I would come up for air and see people and then sink back down into this very, like a murmur. Everything was a murmur. It was so weird. I've never felt that way, but I had never experienced that before. My dad died. And with my mom, it was, and then of course I would fall apart as I'm driving, the tears, boy, Niagara Falls. With my mother, I did not go through that, but I did go through that numbness. And I'm still waiting for, like you said, that damn break, and it's just, and I also have my husband that's, bedridden. So, but it was just very strange. So I just decided, well, I'm just gonna let it ride and we'll see what happens, and I'll tell you, it's been 4 years and her bedroom door is still closed and it is exactly the way it was. I have dusted it and vacuumed. It's the same way it was 4 years ago. But there was a doctor who said to me, if you're still feeling this way after 1 year, this was like 2 months after, he says, you ought to see someone, a therapist. I'm like, okay, well, I haven't seen one yet, but it's just, I think just it's normal, right? Everybody, yeah, just dealing with all her things, all her clothes. But I'm gonna make myself do it. I did it for my husband's closet because that was also a form of grief. He'll never wear those clothes again, shoes. And so it was actually very emotional. And I cried several times as I folded his things and took them to Goodwill or, made other donations. And it was like, when his clothes were thrown into this big bin, and I'm like, it was like throwing away a part of life, of our experiences, but I said, no. I mean, it was just very emotional. But I had to be practical about it, but anyway, I think that was a denial, and I just let the emotions come out, and, he's still here. And they say time heals, I don't know, but they don't tell us how long it takes, and I'm sure we never get fully over anybody who passes.
And then the grief of COVID doesn't help on top of everything.
Yes. And Melissa just joined us. Hi, Melissa.
Hey,
How are
sorry,
you?
I've been packing because I'm going to North Carolina to see my mom, so I left my camera off. But I wanted to share a quote that I had come across in my devotional a week or two ago, and this lady wrote. She said, "My mother's health was declining rapidly, and the sadness of the future threatened to steal the joy of the present." And that really hits. But they say, Alzheimer's is the slow goodbye, the dementia, and it really is. And my mom's much, much weaker now, and this could be my last trip. I don't know. They are moving her on September 1st. They decided to wait and move her on September 1st to skilled nursing out of assisted living. And she can't really sit up straight. She's always hunched over now. The muscular degenerative disease that she has, she can't sit up. She can't do anything on her own. And so, so that's the timing of my going, is so that I can be there a few days before, and then like a week after they move her, to try to help her acclimate. But I will also wanted to add to Dura's comments about journaling. I did a grief share class through my church when my dad passed away, and it'll be 2 years in November. And like you, Dura, I mean, every day I miss him. But the journaling is a really good thing. So with the grief share class, they would give you a prompt that you could choose each week. But I found that if I just sat down and just started writing about whatever it was going on, that there's something in the brain that when you're writing it, other stuff comes to the surface. And I was able to put on paper what I couldn't figure out was wrong with me that day, or what was bothering me, or what was I having trouble with. And I think the journaling really does help. There's something with the brain in that process that helps stuff come to the surface. So I should do it more frequently. I haven't really done it much since I finished the grief share class last summer, but it is a good practice that helps, I think, helps you process stuff.
That's a wonderful. Thank you for sharing that, Melissa. And you and your family and your mom are in my prayers every day.
Thank you.
The journaling, just because we have technology nowadays, I'm not a writing down. I mean, I love writing down and taking notes, but I've never journaled ever. I just not into that. But as you all know, I can talk. So I wonder if you can record your thoughts. You can do it on your iPhone. There's an app, Notes, I think it is, or wherever. If you can just talk into it. Dura taught me a really clever thing with a phone. Just hit record. Like if you're going to do like with photos, right? And then but hit the video and just record your thoughts. And then you can play them back later if you wish to do that. But it might also help you figure out because sometimes, I mean, we think a lot faster than we write. So if you're that kind of patient person like I am, that might help you. Or if you're driving and you're thinking of this and that, just be safe. No texting and driving and all this stuff. But that might also be a way that you can journal just verbally. So, but thank you, Melissa. That was those are really good points that you made. Oh, and there's Suzanne. Do you want to share anything today, Suzanne? No? Okay. Well, we're glad that you're here.
All right, and it is now just a little after 12.
Ooh, it is, okay.
So I'm going to turn off the recording because I kept it recording through this. I thought we were all sharing some very valuable things. When we're talking about grief, we learn from each other. And so normally I will stop after the presentation, but part of grief is grieving with one another and helping each other get through it. And our stories help others identify their own story. So thank you for sharing, and I'm going to stop this now.